you so much, Kayla, and I am so pleased to be presenting to this crowd. As Jeff mentioned in his very warm introduction, I am a Michigander. If you could see me, I would be holding up my hand in the shape of a mitt and would point out exactly where I'm from. I grew up in Traverse City, Michigan, and I went to school in Ann Arbor and still have lots of family members in Michigan and love to get back there as often as I can. So that's a little bit about me. And Jeff did mention that I did schooling in Michigan, also the University of Chicago, and I did a postdoc actually at the University of California at San Francisco, UCSF. And then moved to Philadelphia and did some research there, and am now back in California. And what I do, I call addiction health services research, and that's investigating gaps in the substance use continuum of care, identifying unmet need for services, and that's what really got me started, got me launched on investigating recovery residences. My postdoc was all about addiction treatment research. In Philadelphia, I worked at the Treatment Research Institute, but the more I learned about substance use treatment, the more gaps I saw, and the more places I saw where recovery support services could really fill those gaps. And because I was in Philadelphia, there was a lot of really good work going on with respect to mapping different kinds of recovery support services and supporting recovery housing. And that's where I met Fred Way and got involved with NAR. And it's just been a wonderful snowball from there. So I'm very pleased today to be presenting on the evidence base for recovery housing. As a researcher, it's now my kind of passion to be contributing to this evidence base, this research on recovery housing. So next slide, Kayla. So before I get started in the presentation, I just want to acknowledge that this work is supported by the National Institute on Alcohol Abuse and Alcoholism, NAAA, and that's supporting a study that I'm currently conducting, which I call the NSTAR study. And that's a big federally funded study, and if we have time, I would love to talk about it. But I don't do work on the NSTAR study alone. I have a whole team of collaborators that really support this recovery housing research, and I want to make sure that they are mentioned as well. Kate Karaka-Jaffe, Mina Subaraman, Jason Howell, who I also served on the NAR board with, Lee Kaskudis, and Deidre Patterson. Next slide, Kayla. So what I want to do with this presentation are really just three things. I want to highlight the importance of research on recovery housing. I want to review the evidence base for recovery housing, and I want to discuss critical gaps in knowledge and ongoing efforts to address them with respect to recovery housing. Next slide. So before I talk about research on recovery housing, I thought it would be important to make sure that we're all talking about the same things. When I use terms like recovery residences and recovery housing and research. So I know my audience, and I probably don't have to say much about what I mean when I say recovery residences. I mean, this is the Michigan Alliance for Recovery Residences. But I did want to spend some time on this because I remember back in the mid-2000s, 2010, 2011, when this was a really big game changer in the field to have this term recovery residences. Before there was this term, people were talking about recovery houses. They were talking about sober living houses and Oxford houses, because depending on where residences were located, the kinds of services they provided, and sometimes even licensing requirements. All of these things had different names. So when NAR came up with the term recovery residences, it really kind of gave this this field a unifying way to talk about all these different types of residences by calling them recovery residences. But the other thing that they contributed is that you know, regardless of what they're called, recovery residences provide safe, sober, and healthy living environments that promote recovery from AOD use and associated problems. So really just kind of labeling recovery residences and defining what they were, like I said, was a real game changer in the field. Next slide. And so when I talk about recovery residences, I also talk about and use the term recovery housing. This is a little bit different term, but it means largely the same thing, kind of a general and generic term. Recovery residences provide recovery housing. So recovery residences are the physical structures and the setting where people live together to address their recovery. And recovery housing is the services that are provided in the setting where these individuals live. Recovery residence is the physical setting, recovery housing is the service. And I think that the term recovery housing, and I put up on the slide a couple of different definitions of recovery housing, one by HUD and a more recent one by SAMHSA, where we've kind of really fleshed out what this term means and with respect to the service that's provided. But why this is a game changer, as much as the term recovery residence was a game changer, is that it reflects a shift from talking about recovery residences and different types of them to thinking about what these services do as a service delivery modality. Next slide.
I just had an epiphany, Amy. It's like I'm hearing all these people talk about recovery housing, and I didn't understand that that was a limited subset of what offered in the recovery residence field. So it really deals with the services, recovery housing.
Exactly. Yep. So recovery housing is the service. The setting is the recovery residence.
Okay. Thanks for clearing that up for me.
I know they're often used interchangeably, and sometimes they can be, but I really like the idea of talking about recovery housing because, again, it's a service. Recovery housing is a service, and that's a big part of my, you know, my interest in recovery housing as an addiction health services researcher. I study services, so I study recovery housing.
So the services portion, that's the magic sauce, as Jason Howell refers to it, right?
Yep, that's what recovery residences are doing. They're providing recovery housing.
Thanks.
Okay, so along with defining terms like recovery residence and recovery housing, I thought it would be helpful to also define what I mean by research and what that means. So when I use the term research, I'm referring to a systematic investigation designed to develop or contribute to generalizable knowledge. So research systematically collects data to document an existing or fundamental or underlying truth, and it seeks to produce universal knowledge about a population or phenomena under study. Now, because other activities may involve data collection, I think it's worth spending a little time talking about how research is different. So one activity that involves data collection is program or outcome evaluation. And this is a little bit different. Evaluation refers to the examination of the worth, merit, or significance of a set of organized activities supported by a set of resources to achieve a specific and intended result. In general, it seeks to gather information about the state of affairs, value, or quality of a specific program, policy, or initiative, and to equip stakeholders to make decisions about specific program, policy, or initiative. So in terms of research and evaluation, what really crystallizes the difference in my mind is that research is talking about more general things, and program evaluation or outcomes evaluation is really specific to the program, policy, or initiative under study, or what's being studied. So thank you, Kayla, for advancing to the next slide. Why is research important? And why is this generalizable and more universal knowledge important? So granted, I'm biased because I'm a researcher, but I would argue that research is important because it provides critical and objective information on which people can use to make decisions. It helps fill gaps in knowledge so that individuals, both operators and policymakers, can make decisions about services and how they're delivered to individuals who need them. So the other thing about research is that it's also heavily regulated and rigorously scrutinized. So for example, the Office for Human Research Protections, part of DHHS, the Department of Health and Human Services, maintains regulatory oversight and provides guidance on ethical and regulatory issues for biomedical and behavioral research that's supported by HS. Additionally, the FDA also is responsible for oversight of clinical trials for drug and biological and medical device products. Additionally, there's even more scrutiny. There's peer review other fellow scientists who are involved in reviewing the quality and rigor of research at every stage of it, at the research proposal stage, but also at the publication stage. And I would argue that this amount of scrutiny and the process of conducting research lends credibility to the products and the outcomes from it. Next slide.
Amy, what is the general additional incremental cost of the going through all of the bells and whistles and getting the approvals needed for the research to take place? Can you basically say it's like somewhere in the neighborhood of 25%, a third, something like that?
Well, so here's in terms of the cost, you don't get paid to write research proposals.
Right.
So you get paid to conduct the research. So there is an incredible amount of effort that goes into drafting a research proposal. And that is like all on free time, evenings and weekends. It takes a really committed person or someone who has another stream of income, say they're teaching at a university. They have what's called in the field hard money to support these efforts. But it takes a lot of time to pull something like that together. It is definitely not for the faint of heart. So again, I mean, people who are doing the research, who are putting these proposals together, who are wanting to do this work on the weekends and the free time to study certain things that they feel passionate about. I think it says something again about commitment to the topic and what people want to do with the outcomes of this research. I mean, people definitely the work that I do and the researchers that I work with, they all do this because they're committed and they want their work to make the world a better place. It takes a certain amount of a special kind of someone who's willing to go through that, basically, like I said, for free to get the research work funded so that they can do what they want to do. Does that answer your question, Jeff?
Yeah, it does. And we'll circle back later if we've got time remaining to talk about the concept of having a peer recovery coach at the recovery residence here in Michigan. Could you talk a little bit about my understanding, Amy, and this is from Dave Sheridan from like a week ago, was that recovery residence is now evidence-based practice. SAMHSA has, like within the last week, has recognized that as evidence-based practice.
Yep. Yeah, that, I mean, it does get to the importance of research and the power of research, what it can do. You know, through the process of this presentation, I'm going to be presenting all of the research on recovery housing. And I would say, and I'm really glad that SAMHSA agrees, that we've accumulated enough evidence on different kinds of recovery housing, different models, Oxford houses, therapeutic communities, sober living houses in California, that we have good evidence that recovery housing works. You know, hopefully having that recognition, listing recovery housing as an evidence-based practice will, you know, start changing people's hearts and minds about recovery housing, better build a place for it in the substance use continuum of care.
My thought on that is that the research didn't exist 10 years ago. NAR didn't exist 10 years ago. And so this is something that is kind of a new expanding area of research. And the message I'd like to have to everybody listening to this conversation today is that we're going to be, when I say we, MAR is going to be doing something in terms of trying to come up with metrics that we can be collecting to help our researchers like Dr. Mericle. Thanks, Amy.
So the next couple slides, I actually want to talk a little bit about, Jeff, you mentioned the work at Johns Hopkins and their study and kind of what you're thinking about for Michigan. In terms of recovery and you know, why housing is important. You know, this group is really well versed in you know, what recovery means. I put up here the definition of recovery that that I use the most, and it's the one that SAMHSA put together in 2011, I think it was. Recovery is a process of change through which individuals improve their health and wellness and live a self-directed life and strive to reach their full potential. So that this definition, there's several of them at this point, you know, really captures some really neat elements. Recovery as a process, the emphasis on well-being and striving to reach the full potential. But the other thing about this work that SAMHSA did was that it identified 4 dimensions that support a lifestyle in recovery. And this is where I think we finally had a crack, an opening to say, look, recovery housing is important because home is essential. It's one of those 4 dimensions that supports a lifestyle in recovery. Now, SAMHSA just defined home as a stable and safe place to live, but we all know that recovery housing can do much more. All of these other things as well: purpose, community, and health. So next slide, Kayla. So where did SAMHSA get this idea? Well, it seems like a no-brainer that you would need a safe and healthy place to live in order to initiate and sustain your recovery. But there is some empirical support for this. So I put on this slide some research that was done, gosh, back in 2005. And this was a research study that looked at whether providing abstinent contingent housing to individuals. And this is just rent-free housing, not necessarily recovery housing, whether just providing housing helped improve outcomes and improve outcomes over and above what people would receive kind of in the treatment setting. And what this study found, and is what's depicted in this graph, so this lower line here, that is basically the group that got treatment and no housing. And then there are a couple of other groups. One is a group that got abstinent contingent housing, and the other group that's very closely in line with it is the group that got housing, but there was no abstinence contingency attached to it. And what this graph shows is that, that when you provide housing, you get better outcomes. The outcome that they looked at here was the proportionate abstinent at each time point. And this decreased over time in all conditions. But the folks who had housing are significantly different from those who weren't provided housing. That's, basic evidence that, just housing, just making sure that housing was provided. And I should say that this was a group of individuals who were currently homeless at the time and who were receiving treatment for substance use disorder. So there was definitely a need for housing. If you meet that need, you can improve outcomes. So next slide. And there's even more evidence. So that study, looked at and really provides some solid evidence that if you provide housing, you can improve outcomes for people who are accessing substance use treatment. But again, this was a homeless population, and it doesn't really say much about the housing that was received. Is this does this speak to recovery housing? And these findings generalize to non-homeless populations? And so what I put up in this slide is a study that was conducted by researchers at Johns Hopkins. And they conducted a number of different studies over the years on what they call reinforcement-based therapy. So reinforcement-based therapy is a multi-component intensive day treatment program based in part on the community and reinforcement approach. Reinforcement-based therapy, or RBT, involves cognitive behavioral group therapy, abstinent contingent recovery activities, vocational assistance, individual housing, and housing support. So this study that I'm presenting on the purpose of the study was to highlight and determine whether the abstinent contingent recovery housing was effective for sustaining substance use, and to compare that with folks who got the recovery housing as well as the reinforcement-based therapy, and to compare both of those conditions to folks who were recruited from detox and just kind of got treatment as usual, or usual care, and that was just kind of a referral to the community. And then what this study oops, if we can go back, because I just want to review what those lines are showing. So again, in this graph, we see abstinence rates for the participants at different time points. The bottom line is the usual care. So again, lower than the folks in the other two groups, and both those two groups received recovery housing. The group at the top are the folks who received recovery housing plus the reinforcement-based therapy. And their outcomes are better at each time point, but there are significant differences between the folks who got recovery housing and those who didn't, except for the 6-month mark. I think that they only got 3 months of recovery housing. So I think that the effects of recovery housing diminished a little bit. But what these researchers also looked at was the contribution of the reinforcement-based therapy. And they really drilled down to say that what they thought the reinforcement-based therapy was doing was helping people stay longer in the recovery residence. And that was really probably what was driving the outcomes. So that's a really neat study because they really dismantled this multimodal intervention, and they kind of parsed out the different components, the recovery housing component from the reinforcement-based therapy. And Jeff, I can see why you're interested in this, because I can already see parallels to what you're thinking about with respect to recovery housing and adding a recovery coaching component to that.
Absolutely. I mean, my thought has been that it makes sense to train a workforce to operate the recovery residences here in Michigan, throughout the United States, with some type of, I would meld and mixed together, the peer recovery coaching. CCAR is the one that I went through, and then State of Michigan has its own peer recovery coaching program. But it makes all the sense in the world to me to have a peer recovery coach trained with some additional recovery residence training to be present in every recovery residence here in the state. And the difference between what is on your third line there versus your second line, assuming it's attributed to the once a week IOP or counseling, I'd like to have the same type of study done, but instead of having a clinical person doing the once a week IOP, have a peer recovery coach, which would be significantly less money. And it would be, I think, perhaps more available. And so that's, and I know we've spoken in the past about the cost of doing this. You want to share what your idea of what the cost is to, like, for instance, the Philadelphia study, the Johns Hopkins study, I think costs $3 million.
Yeah, those things are quite pricey, because and when you randomize people to a certain condition, even if it's a drug study, you don't expect people to pay for that treatment.
Right.
So, if you're wanting them to go to recovery housing, you would want to pay for the recovery housing, and the Johns Hopkins study did. They pay for the recovery housing, and you have to pay for the treatment and the counselors. So, above and beyond the costs that you would have just to collect the data and to pay the scientists, there's significant costs associated with the interventions that you'd be providing.
Well,
go ahead.
I was going to say, in addition to those costs, there'd be the cost of providing the IOP person and or the peer recovery coach person, and then
Exactly. Yep.
Good by you folks, and so.
Yep. That's cost of the intervention.
So I have to go begging on my knees to the state of Michigan or the federal government for more money for research to be done. So I think this is absolutely critical.
So if we could go to the next slide. I like you, Jeff, am a fan of the Johns Hopkins study and that work. My biggest critique of that is that we don't know much about the recovery housing that was provided. That's kind of a little bit of a black box. And my guess would be that it was probably level 2-ish housing, but who knows? So I put up here the NAR levels of support. And again, we know that there's a big range from level 1 to level 4. So we have some evidence that recovery housing helps, from the Johns Hopkins study. But what exactly was that recovery housing? I don't know. Thankfully, there's other research on recovery housing that has been specific about the different kinds of housing studied. There's more research on level 1s and level 4s than the stuff in between. But as I alluded to before, there's a decent amount of research even on those in-between levels. So let's walk you through that. If we can go to the next slide.
So the level 1, that's like the Oxford houses, which I don't know that there are any here in Michigan. And in Michigan, most of the operators are running level 3s with maybe lesser percent running level 2s and a few level 4s. But
yep. So speaking of level 4s, I put a slide up on Therapeutic Communities, or kind of as they're shorthanded, TCs. So that has often been held up as an example of a level 4 kind of recovery residence. And TCs have been defined as long-term residential treatment that's recovery-oriented, comprehensive, and uses active participation in group living activities to drive individual change. So what differentiates TCs or the TC model from other kind of residential treatment is really that emphasis on peers and the peer culture and peer support. And that's kind of what puts it into the recovery housing basket, is that emphasis on peer support. And there's actually strong evidence for therapeutic communities. You don't see therapeutic communities as much anymore. There's been a little bit of rebranding of what a therapeutic community is and what that encompasses. Retweaking of the model. But mostly I think that it's hard to find TCs these days because of reimbursement rates. It's just really hard to fund a long-term residential treatment stay. But there is, I put in the slide, the website for Treatment Communities of America. There's still an organization that advocates for and serves as kind of an organizing body for therapeutic communities. So let me just run through the research on the next slide, the evidence base for TCs. And there's actually quite a bit. These have been really well studied. So I put some sites up for a literature review that looked at 30 publications based on 16 studies of TCs. And these found that 2/3 of the studies found significantly better substance use and legal outcomes among the TC participants. 5 studies found superior employment and psychological functioning outcomes. And they also looked at length of stay and length of stay in treatment and participation in the TC and in subsequent aftercare were consistent predictors of having better recovery outcomes. So TCs, there's so much of so many studies and so much evidence on TCs that it's NIDA has listed, the National Institute on Drug Abuse has listed TCs in its publication on the principles of drug addiction treatment and released a specialized report on TCs as a treatment for substance use disorders. And when SAMHSA had its National Registry of Evidence-Based Programs and Practices, NREP, different TC models were listed on NREP as well. Next slide.
The TCs, are they typically level 4s that have some type of clinical?
Yes, most definitely clinical. So much so that they're classified as treatment. That again, so people who study them would talk about them, and people who provide treatment in therapeutic communities would identify them as long-term substance use treatment.
So, and they've got the funding because they're treatment, I'm guessing. I mean, the funding to do the research. Yeah.
Yep, I would guess that. Although it's tough because again, the model is long-term residential treatment, and insurance providers and contractors, city and state governments, nowadays pay for 90 days of treatment, residential treatment. It's really hard to extend that out. And to find, I've talked with operators of TCs, and they've had to be really creative of how they've had to modify their model to fit within a 90-day paradigm when TCs, are usually 6 months to a year to do that treatment.
They kick you after 90 days and say you're all healed, right?
Yeah, of course. Wouldn't that be great? Wouldn't that be great?
Well, send no more, my child.
So the other really strong pile of evidence comes from research on Oxford houses. And so Jeff talked a little bit about Oxford houses as kind of a level 1, which these are peer-run recovery residences. There are no staff. These are usually in residential neighborhoods. And there's a really strong evidence base for Oxford houses. And I just want to walk you through some of that research. So next slide. So the evidence base for Oxford House comes from one national outcome study and 2 randomized trials of Oxford houses, resulting in over 200 publications on Oxford houses and Oxford House residents. And this work has been done by Dr. Lenny Jason at DePaul University, who's been studying Oxford houses for, more than 2 decades. I don't know the exact number, but it's for sure more than 2 decades. And what they found in their national outcome study, which involved 897 Oxford House residents, is they found that the Oxford House residents had increased employment and income, and that that over the year or at the end of the study, they had low levels of involvement in the criminal justice system. So in a study where they randomized 150 individuals who were recruited from inpatient treatment and randomized them to Oxford House or usual care. I think the usual care for that condition was just kind of referral as usual to aftercare. The Oxford House residents at the 24-month follow-up, again, that's a 2-year follow-up, that's a really long time. They followed these folks. They found that they had lower substance use and incarceration rates, and they also showed that the Oxford House residents, compared to the kind of the usual care condition, had a higher monthly income. And they also did another trial and a study. They randomized individuals to Oxford House, a therapeutic community, or again, kind of the usual aftercare condition. And they found that those assigned to the Oxford House condition, again, followed up at 2 years, received more money from employment and worked more days, and achieved higher continuous alcohol sobriety rates. So again, some really strong outcomes and evidence for Oxford houses. So much so that when SANSA had its NREP database operational, the Oxford House model was also listed on it. So that's Oxford House research at the kind of level 1 level, TCs at the level 4 level. What about everything in between? And it sounds like, Jeff, in Michigan, that's pretty much what recovery residences are doing, kind of a level 2 or level 3.
There's one Oxford House in Grand Rapids, and that's the one Oxford House in the entire state. So almost all of them are 2s and 3s. I was wondering, when you're talking about the research, the other research other than the Johns Hopkins study, is there anything where they attempted to equate the dollars saved to the economy, to the public, as a result of having people working, paying taxes, not committing crimes, etc.?
Yeah, so the DePaul group, I think it was for, can't remember which study. I think it was their Oxford House versus usual care trial. They did look at, they did do a cost benefit analysis. And I think that that's really the only work that has been done. And they did find significant savings with Oxford House. This actually might have been the TC study, because they had to cost out the cost of the service, the recovery residents, and weigh that with the benefits of the offset of not being in the criminal justice system, employment and earnings and income and things like that. And again, they found things looked good for people who were in the Oxford House condition. But that's definitely, and I'll talk about this kind of towards an area where we definitely need more research, is kind of the health economics, just the cost benefit and cost of the cost savings that can be involved when people stay in recovery residences and work on the recovery.
Yeah, the number I heard, and I don't have a site for it, I think it probably came from Kevin O'Hare, like 3 or 4 years ago. But there was something where he was saying there was some study that showed like the number was 40 to 1. So for every dollar invested in recovery, society gets roughly $40 in return, and more taxes paid, less crime, et cetera, et cetera.
So I unfortunately did not list this as one of the references citations in this presentation. So Jeff and Kayla, I'm going to send that article to you from the Oxford House research after this presentation, so that you can send it out to the members, because that's a really good piece of evidence, of research to have in your back pocket.
Sure. Yeah. Well, to the business people that make decisions at the various governmental and local municipal zoning things, it's a nice argument to say, economics makes sense to have people in recovery, and that doesn't put a value on the value to a child having their parent in recovery, or the value to a spouse of having their spouse in recovery.
Yep. So I'm going to next talk about the research on sober living houses. But I do want to interject as we're talking about costs. Both Dr. Jason's research on Oxford houses and Doug Polson's research on sober living houses in California, they've focused a lot on criminal justice populations. And so they've looked at and tracked involvement in the criminal justice system. And criminal justice system stay is expensive. So keeping people out of the criminal justice system is a big cost saver. All of those studies, and some of them are listed, and you can find them in this presentation, that look at criminal justice outcomes and show the benefits of recovery housing for reducing involvement in the criminal justice system. Think about that as a money saver. Okay, what about everything in between, the NAR level 2 and 3 residences? So there is some research. So there's Doug Polson's research on sober living houses in California. I've conducted some research on some other types of residences in Philadelphia and Texas. It's definitely dwarfed by the amount of research on Oxford houses and therapeutic communities on TCs, but it's still strong, especially for sober living houses in California. So next slide. Oops, I think we went one too far. There we go. So evidence-based for the sober living houses and other models. Doug Polson is a colleague of mine. He's a researcher at the Public Health Institute. He's been conducting research on sober living houses in California. Sober living houses in California are very solidly level 2 residences. They have a house manager, but don't provide services to the residents. He's been conducting research on sober living houses, gosh, at least a decade, probably 15 years. In the course of his work, he's looked at residents in Northern California and in Southern California. And in both those studies, he showed improvements on substance use, employment, and criminal justice outcomes. He's conducted 3 different studies at this point. He's currently in the middle of his 3rd and just got funding for a 4th. So again, the accumulation of evidence on level 2s is also increasing. The work that I did in Philadelphia, those were a mix of kind of level 2s that were also trying to really maximize the support from the community. So there was an effort to kind of network and provide some other kinds of services to residents. A lot of the Philadelphia residences also were connected with treatment programs. So there was a good linkage between the recovery residents and the treatment program. It was a small study that I did in Philadelphia, but in terms of abstinence, in terms of staying in the house for a very short 3-month follow-up, the outcomes were encouraging. And I also did a study in Texas that showed similar encouraging results, again, for a shorter follow-up time of just 3 months. But there are these other models that have been studied. So again, there's growing evidence for other kinds of models. But like I said, the level 2 and level 3 research is definitely dwarfed by the amount of Oxford House and TC research. So let's go to the next slide. Hopefully I've convinced you, and it sounds like SAMHSA is convinced that we have good evidence that recovery housing works. We've also tried to think about and do research on how they work. What are the things that are associated with these good outcomes? So folks have looked at social support and other social network characteristics. Their social support in terms of giving and receiving support. Lenny Jason's work is really focused on this currently. Social network characteristics, whether or not you have substance users in your social networks, that's been associated with outcomes. Also other things like sense of community, involvement in 12-step groups. There's also really interesting work that's being done by David Best about how kind of involvement in these communities at the house level or in mutual help groups really changes one's thinking, one's identity, and kind of puts someone on a track of being someone in recovery, as opposed to, this is a very outdated term, but I think that's how they talked about it in the article. Instead of the identity of an addict as, switching over and thinking about yourself and learning to live your life as someone who's a person in recovery. And I would argue that the social support, the social network characteristics, and kind of these interpersonal things that may go on with, how people are thinking about their identity, these are all aspects of recovery capital, these social and interpersonal things. And this is also being increasingly studied in the recovery housing literature. I've listed a site here for a study that was conducted in Florida that really lays out in a really nice way how recovery housing can support different aspects of recovery capital. So that's a really neat study, and I really hope that that future recovery housing work, incorporates measures of recovery capital into it more specifically.
Amy, this is on late breaking news. This is like within the last hour. The OROC, Michigan Office of Recovery Oriented Systems of Care, are considering trying to get funding for John Best and John Lehman's, I'm sorry, David Best and John Lehman's our recovery capital platform.
Direct cap.
Yeah. Exactly.
Neat. That would be great. Yeah, I mean, recovery capital, I'm guessing that you guys are familiar with that concept. I think it's just a really nice way to think about all the different resources that people need to initiate and to work on the recovery. And I love how that work, that article by David Best and colleagues, really mapped out how that looks, or what that looks like in the recovery housing setting.
As explained in the Scottish brogue. Right?
Yeah. Yes. So let's go to the next slide. What are the critical ingredients of recovery housing?
Amy, I wanted to introduce for a minute. I know that you are short on time today, and we are reaching that 5 o'clock hour mark. We do have a couple of questions. So just if there's anything that we want to maybe wrap up so we can answer a couple of questions, or maybe we can just get questions answered via email after the webinar.
Well, let's definitely have questions come to me after the webinar. I'm so happy to do that. Feel free to pass those along. In terms of the critical ingredients of recovery housing, I just want to mention this very quickly, is an area where we need much more research done. So it's great that recovery housing is being listed as an evidence-based practice through SAMHSA, But boy, gosh, it would be really great to have more information about what recovery residences are doing, so that we can have recovery housing evidence-based practices. And that's an area where we definitely need more research. We need more research on how and whether recovery residences are implementing social model principles, what kinds of characteristics of the house and how it's run are associated with better outcomes, and also neighborhood characteristics. Recovery happens in the house, but houses are located in neighborhoods. The resources that are in and around, and the risk factors that are in and around recovery residences, that's also an interesting place to look at, or interesting to look at, and hopefully we'll get more research on that. So let's go to the next slide, because I also want to comment on, there's also been research on recovery residences and groups of residents who might need additional services or additional help, or be more vulnerable. Kayla, if we can move to the next slide. There's been a lot of work thinking about who can be served in recovery residences. And my hat is off to the folks at DePaul University. Can folks hear me?
We can hear you fine.
Okay, so for whatever reason, the slide is not advancing on my screen, which is not a problem, because I'll just power through. But in terms of who benefits from recovery housing, we've done research on, DePaul University has done research on Oxford houses for women and children, Latino populations, Native Americans. There's research on recovery housing for sexual and gender minorities. And in terms of differential effects, there's really strong evidence about length of stay. If folks are interested, I'm happy to send some more references and sites, but there's evidence to support that a 6-month length of stay is really a key milestone in reaping the benefits of recovery housing. I just want to review some of the gaps in knowledge. You've probably picked up on this from how I've been going through the research. The research is on recovery housing. There's really great stuff. I don't want to have that be lost in this last slide. But the research is fragmented. We definitely need more research on level 2s and 3s. We need more research on kind of pointing to evidence-based practices in recovery housing, what recovery residences are doing. So this is the gaps in knowledge, the next slide. We also need to have, key questions answered about access and availability of housing. I'm always embarrassed when people ask me how many recovery residences are out there, that I can't give them anything more than an estimate. And that is problematic, because we need to be able to answer questions about access and availability to recovery housing. We are always striving to increase the rigor of this work. This slide on the screen is a paper that I wrote with Doug Polson and researchers from Oxford House that talks about some of the challenges, but also some of the rewards of doing research on recovery housing. My last thing that I just wanted to cover is that I presented a lot of information on recovery housing research. All of this research is federally funded. It's funded by the National Institutes of Health, the NIH the platform, a searchable database of NIH-funded research. So the next slide, I included a snapshot of this search platform. So if you type a name in of your favorite researchers, you can find out what they're up to, and you can even search general terms like recovery housing or anything that you're interested in. It will spit out who's doing research on it. And I've listed 5 studies on this slide that are currently ongoing about recovery residence residence research and recovery housing research. It's, I want to impart that it's still a work in progress. We know that there are gaps. We're working as hard as we can to fill them.
That's
And
excellent.
I can't believe I took up so much time with these slides. I really wanted to be able to address your questions.
Well, it's getting up there close to 5 o'clock. So if anybody has a question, please put it in writing. Send it to Kayla Hall at MAR, and we'll send it on to Dr. Mericle for her response. I'd like to thank Amy, and also thank the Michigan ORASC office for helping to fund these type of seminars. And if anybody has any questions, they can contact Kayla Hall at MAR if they have an issue about how to get a hold of this, any of the things on the website. So having said that, thank you so much, Amy.
No, it was my pleasure. And also, if people have
Yes, thank you. Also, hello?
Yeah, I'm still here. So I just wanted to add, if people have questions or can't get a hold of some of the articles that I've listed in these slides, I'm happy to send those along as well.
Thank you.
Yes.
With that, I think we're done. We're done here. Everybody have a good Friday.
Bye.
Bye-bye.